Learning is a treasure that will follow its owner everywhere. A very good afternoon to respected seniors and friends. Myself, Dr. Jaya Tulaskar, convener of today's webinar, extend my warm welcome to all of you. I feel extremely honored to welcome you all in part 6, that is concluding webinar of PPH comprehensive series. This webinar is in collaboration with 4 AMOX societies. AMOX High Risk Pregnancy Committee, AMOX Emergency Obstetric Committee, AMOX Website Committee, and Amravati OBGY Society. I would like to extend my thanks to chairpersons of these committees, respected Dr. Chaitanya Shembekar sir, Emergency Obstetric Committee, respected Dr. Pranjal Sharma madam, Emergency Website Committee, respected President and Secretary of Amravati OBGY Society, that is Dr. Suyega Panath madam, and Secretary Dr. Anita Bogde madam, for collaborating with AMOX High Risk Pregnancy Committee. And special thanks to Corona Remedies and Core Connect, because of which we are able to telecast today's webinar. We have with us our most respected President AMOX, Dr. Rajendra Singh Pardesi sir, always been a source of inspiration and encouragement for all of us. I welcome you, sir. I request respected sir to address the webinar.
Good afternoon, everybody. Respected Dr. Sujata Dalvi, Dr. Kiran Kurtakoti, Dr. Rashmi Kahar, our ever active chairperson of AMOX HRP committee, Dr. Chaitanya Shembekar, Dr. Pranjal Sharma, and President Secretary Suyoga and Ankita of Amravati Society. And most important stalwarts, I salute to them, all 3 stalwarts, Dr. Thomas Burke, Dr. Shilamane, and Dr. Priti Kumari. And these 3, they are really working in this field of PPH prevention and management. I salute to those who are really working for the women's health. And the 3 really, the work is really adorable. First, I wish to congratulate Dr. Rashmi Kahar and team for organizing all this series of PPH. As all you know, PPH is a major cause of maternal mortality. I need not to tell you the details, but proudly we can say now we are shortly reaching the goal. Now India has been 103, and proudly we can say Maharashtra has reached 38, and now we have target to reach single digit MMR maximum by 2030. Now this is the last episode of that series, which will be on advocacy of PPH and which will with an interview based session. These are the 3 stalwarts and they will be interviewed by Kiran Kurtakoti sir, our ever active AMOX Vice President, Dr. Surekha Taide, Dr. Anil Sakhare. I know you all will be waiting for your active MOC started by Dr. Jaya Kore for the scientific interactions by these giants. I wish every success to this wonderful concept of interview-based session on PPH. Thank you so much. Thank you.
Thank you so much, sir, for your words of wisdom, and thank you so much for being there always with us. Abhishek, next slide. We are waiting for Sujata ma'am. She will join in between. So moving on to our first session or interview of our first interview-based session, advocacy of PPH. Respected speaker for our first session is Dr. Thomas Burke, sir. Sir is an emergency care physician from Boston, and our interviewer is our very own respected Kiran Kurtakoti, sir. Next slide, please. It's my great privilege to introduce and welcome Dr. Kiran Kurtakoti, sir. Sir is Vice President AMOX. He has been ex-chairperson MTP Committee FOXY in 2009-11, ex-chairperson MTP Committee AMOX, ex-chairperson Medical Education Research and Training AMOX. Sir is director at Shashwat Multi-Speciality Hospitals,
It's okay, Dr.
Sanjeevan
Jain.
Hospital, Pune.
It's okay, fine, Dr. Jain. Let's get on with
Thank you so much. Yes, sir. I welcome you, sir, and I request you to please introduce and welcome our speaker for today, Dr. Thomas Burke, sir.
Yeah. Well, on behalf of Amox, I welcome you all for this fantastic session, which is an interview-based session. And indeed, it's a great pleasure and honor to interview none other than Dr. Thomas Burke. Well, when I went through his CV runs into 74 pages. I have never seen such an extensive CV in my lifetime. Okay, so that itself speaks volumes of the amount of work that you have done, Dr. Thomas. You're working as an associate professor, global health, Harvard Technical Chan School of Public Health. Dr. Thomas is currently working at the Mass General Hospital, popularly called as Mass General Hospital, which is very close to the River Charles. River Charles is a very beautiful river, and besides the River Charles, there are many institutes. One of them is Harvard, the other is MIT, and of course, third is the Mass General. So, Professor Burke, we definitely hope, wish and pray, just as you are coming to India to give us talks on PPH and everything, we hope, wish and pray that once the entire contingent of Amox see and probably you take us to a visit to the Falconers, to Vermont and New Hampshire and all the other places, beautiful places around Boston. So thank you so much. Thank you. And on Amox platform, I also welcome Dr. Preeti Kumar also, who is doing a fantastic job as far as PPH is concerned. Now, before we get on, a few questions. I mean, when I asked Dr. Rashmi, what should I ask Dr. Thomas? Does he have anything else in his mind? What questions does he have in his mind? So Rashmi said that he has just said, ask anything on PPH. This shows the amount of work or the amount of confidence that you are doing in this field. And we really are happy that you have given so much to our organization in form of in form of the guidelines also, and in form of the bundle approach also. So, well, we should begin right now with a very basic question. You know, when it comes to there are a lot of lines. So, Dr. Thomas, what is your opinion on the exact definition of PPH? Because when it comes to PPH, every society has got its definition of PPH. So according to you, what suits best for a country like India when it comes to the exact definition of PPH?
Thank you. First of all, I want to say thank you for having me here. And I've, you know, for my goodness, the last 6 years have developed such admiration for all of you. And Dr. Preeti Kumar, I just think is an angel on earth. And Dr. Poonam, and I see now looking around so many familiar faces. So this is really it's such a privilege, and you inspire me. You know, I will say for a moment that you know, these days the politics in the world and where things are going are very frustrating as we look into the future and have hopes and dreams for our children. But you all absolutely are refreshing and inspiring. And so the question in terms of the definition of PPH, I think that's a great question. People have been struggling with this, as we all know, for several years. And you know, there's a definition, and then there's, you know, the clinical, when does it matter? And when do we want to call it something? Certainly, the definition of a certain amount of blood loss, 500 cc's of blood loss, doesn't make any sense in a clinical sense. So I suppose if you want to do research and study something from a precise amount of blood loss and metrics, you know, you then really would need to know what someone's blood volume is before and then collect their blood volume of loss at birth using sheets that are designed to do so. But for all the rest of us and for everybody else in the world that is actually practicing healthcare and delivering mothers and delivering babies and keeping mothers safe, it's really about a much more holistic approach, which is, how healthy is mother going into, what is her blood volume? Someone that is 60 kilos is going to have a very different blood volume than someone who's 85 kilos. And that really needs to come into play. If you're stuck with a certain volume of blood and yet they have a very different constitution and size, then it's different. And we also need to understand blood loss. If it's trickling out over 12 hours, or if you're into 5 minutes of blood loss and it's coming out at a rapid rate, it's a very different scenario when the body is significant, a woman is significantly at risk in a very different way. So, I think the appropriate, we've thought of, everybody talks about this, and I think the right answer really is, and now research is turning this way too. It sounds simplistic, but it's not. If mom is in the eyes of an experienced provider, if mom is losing blood, that makes you as a provider a little bit anxious. If you look and with your experience in having delivered mothers, see this and taking into account the characteristics of this mother's health, you think, my goodness, I'm a little worried. That's PPH. And that sounds, it sounds simplistic, but that's what we know to be true. It's much more accurate than saying, oh, she's lost 550 cc's of blood. Let's say she stopped bleeding. She's 85 kilos. And that's silly then, of course. So.
Yeah, thank you so much for that practical work. So anything which makes the obstetrician anxious is PPH. I would
absolutely. Yes.
Thank you. What is your point on the shock index and modified early obstetric warning score?
Oh boy, you're getting so the shock index. There is so some of the originators of the shock index are from Brazil and are good colleagues of all of ours. And there actually is so the shock index. If you see a concerning shock index, it's probably late. As we know, women that are delivering are young, and they usually have physiology that can compensate fairly significantly. So when the shock index begins to enter a concerning realm, mom is we want to catch women before they go in and have their shock index become concerning. So one of the concerns I've always had about the shock index is to use it primarily to say, oh, a shock index is okay, so mom is okay. We all know that you don't have to be hypotensive in order to be sick, especially with a young, healthy heart. We all know that you don't necessarily have to be profoundly tachycardic to be sick with a young, healthy heart. So I think the answer to what you just described is only use the shock index and make sure we teach people that the shock index is additional, it's ancillary, it's an extra vital sign. Don't rely on it primarily. Don't ever say the shock index is fine and therefore mother is fine. In fact, with good postpartum monitoring, we should be capturing women at risk and in trouble before the shock index begins to give us trouble and give us concerns. So I think the shock index is helpful, but we have to make sure we teach people properly how to use it. Use it as an additional vital sign. Don't say the shock index is fine, so we don't have to worry, because then we will lose mothers and we will be in trouble.
Okay, fine. Well, finely put. The next question is, as far as the antenatal risk factors are concerned, one of the prime antenatal risk factors is the entire placenta accreta spectrum. So, how would you address to that spectrum? I mean, any kind of advocacy that you would advise to all those patients who have got a previous C-section or a previous myomectomy or a previous surgical curettage, whether they should be assessed as soon as they conceive or at the 16, 18 weeks for accreta or for anything else? I mean, what is your take on that?
Yeah, you're describing a problem that is really escalating around the world, especially in settings where the C-section rate is high. As you know, we have places all around the world now where C-section rate is high, in some places is 90%. And in those settings, we obviously now see accreta, and we see subsequently we see life-threatening hemorrhage, and we see loss of life. I think the important feature is in women who have had prior C-sections that during pregnancy that she's obviously properly evaluated. But I think most importantly is that we think in advance of where should this woman deliver, and the push should continue that women deliver in an appropriate setting for her to be safe. So what does that mean in terms of accreta? Now, we do know, by the way, and this has now been, maybe as many as 10 studies have come out that you can temporize a hemorrhage from accreta if you're in a lower level facility, with or retained placenta, with a uterine balloon. So I would make sure that people know that to be the case. There were concerns that a uterine balloon, may actually worsen the circumstances, but I think that's pretty well seen that you can actually, in a pinch, temporize with uterine balloon. But short of that, I think we want to make sure that mothers are properly monitored during pregnancy, and that in the event of accreta, that we have women in places where surgical management and blood is able to be transfused, and so she's in the right place for her delivery.
Coming to the next molecule, thank you first of all for return of the ergot alkaloids, because when we were studying as postgraduates, we have used ergot alkaloids left, right, and center without any complications. But suddenly, about 5 years back, there was a ban on ergot alkaloids, probably because somewhere some paper published that patients develop angina. But now in these new guidelines, in the PICO guidelines, ergot alkaloids are now back. So we are very happy with that. So what is your take? Why have we brought them back again into the PPH bundle? And what is your take on that? I mean, ergot alkaloid vis-a-vis oxytocin.
Okay, so did you say ergotamine? Is that what you're asking about?
Methyl ergometrin, yeah.
Yeah. So it's not in the PPH bundle per se, other than as if there's oxytocin failure, and as you then have a sequence of uterotonics. I don't. It's a really great question in terms of what is successful as oxytonic and where. And here in the United States, there are we have a whole sequence, and the sequences are different in different facilities. And I think what's really important is that because of some side effect profiles, that you use what you're comfortable using and what you have in your facility. I think at large, what I'm focused on, and many of our colleagues on this call, and really in the very lower level facilities, where really what they have is misoprostol and what they have is oxytocin, and they don't have other advanced uterotonic agents. So I think I don't think I'll go into more detail in terms of that because the PPH bundle is not designed for the highly specialized centers because those specialized centers have so much more available, such as uterine artery embolization and other advanced. And so then the clinical pathways become different.
Yeah. Now coming to the another molecule, tranexamic acid. What is your take on the role of tranexamic acid in your institute or in the higher tertiary care centers where you're working? Is it a routine practice to give tranexamic acid at least 1/2 or 1 hour prior to all cases of C-section or for all patients who are on the verge of delivery, or only to high-risk patients who are on the verge of delivery or C-section?
Wow, tranexamic acid. Sometimes, and this is a great example where I wish I could jump into the future and look to see where we are 10 years from now. So tranexamic acid, as you know, there have been a number of studies, the big crash trials, and then the woman trials, and then certainly WHO has come in and advocated for it. How do I say this? There have been critical appraisals of tranexamic acid and found that what's called the fragility index of the woman trial. So the fragility index is if you moved one or a few participants over into the other category, what would the results look like? And the fragility index of the woman trial is exceptionally high, which means that the woman trial results are probably not true. And I'm just saying this purely as a scientist. And I think it's really up to WHO and it's up to us to continue to understand and ask questions. But today, tranexamic acid, remains in guidelines worldwide for maternal hemorrhage. And now we use it for all sorts of other things as well. But looked at very, very carefully by world-leading epidemiologists, throws into question whether what we're doing in use of tranexamic acid is actually valid. So in the advocacy question, I would say probably, if it was my daughter, and she was having PPH, I would give it, and I think we should use it. I think it continues to be important for us all as scientists and doctors to ask questions and more research. Even though the woman trial was enormous, it is, took 20,000 women to show a difference. However, if you just moved one woman over to the other column that had PPH, the outcomes would be different. So it's probably scientifically at the moment not valid to say that the tranexamic acid does what we hope it would do, which is really give us big impact in terms of PPH. And I can certainly share the critical appraisal of this to anybody that's interested. Many of you have my email. I'm happy to share that. It was an independent work done. But so I think, I know the Gates Foundation, I know FIGO, I know WHO, certainly support going forward with it. The consequences of that are a lot of work being done, a lot of money being spent in trying to get, a drug into our supply chain. This is not new in medicine. We've had, in my lifetime of practicing medicine, there are many things that we think is the right thing to do. And then 20 years later, we learn that it wasn't the right thing to do. I think tranexamic acid might go that same direction.
Thank you. Coming to the new drug on the block, all the third world countries and the countries with no resource setting are struggling with the process of cold chain. So how do you place carbetocin over oxytocin in this, in the management of PPH?
Yeah. Well, the good news is there are solutions on the horizon with heat stable oxytocin that we have aerosolized oxytocin coming fairly soon. It's been a while, but supposedly coming fairly soon. And carbetocin is I would if the oxytocin was not good, I would use carbetocin, although there's some question still whether it's appropriate for use in active PPH as opposed to prophylaxis. Generally speaking, carbetocin is primarily seen as a prophylactic medication. I think there's good hope that we will have heat stable oxytocin within the next year for all of us, and heat stable oxytocin that is is really good in its properties in terms of active PPH.
Oh, fine. Now coming to the next issue, that is of packing. In India, a particular pack called as Shivkar pack was very popular. Okay, so in case the patient had PPH, you have to pack with roller gauze and just shift her to the tertiary care center. But according to the new FIGO guidelines, this packing is not advocated. Any specific reason behind that, or your take on that?
Yeah. So packing, it's a really interesting question. That packing doesn't generally provide the detention that's necessary in order to address hemorrhage. Now, nothing is all or none. You can imagine a woman that has PPH that is from an atonic uterus, and that she has multiple vaginal tears, and you may want to then place a uterine balloon and then actually pack her vagina. That makes sense. And we've actually had a case from India of cervical tears that were addressed by inserting a uterine balloon into the cervix and then blowing it up just to provide tamponade. We've also published a case from India of a woman who had multiple vaginal tears and had a uterine balloon placed in her vagina that actually was able to arrest hemorrhage. Packing also comes with danger of sepsis, because you really have this wonderful non-sterile environment that now has an opportunity to hold rapidly acting bacteria within it. But by and large, if you need to provide local tamponade, a uterine balloon will be much more successful. They are high volume, low pressure systems, and then they can provide symmetric pressure that packing cannot.
Oh, fine. Thank you so much. And now, before we end, your take on this, on the UBT.
Yeah. Well, the uterine balloon there's interesting. There have been some really important studies that have been published over the years, and I think there are over 100 now that have been published on the uterine balloon. There are two papers that throw into question the use of uterine balloons, and those two papers used improvised devices without blower locks, without actually having a mechanism to fill them, and they also had no way of securing other than a very simplistic method. And using 10 cc syringes. So the two studies that looked at uterine balloon had very delayed administration of the uterine balloons. So if you don't place the uterine balloon until a woman is in class 4 hemorrhagic shock, her outcome, I don't mean to sound crass, but a uterine balloon or anything else that we do it's very difficult to bring back a woman that is near death. So we need to stop hemorrhage early. We need to stop hemorrhage at the time of hemorrhage. Make sure she doesn't collapse into DIC as best as we're able. Uterine balloons, there are a number of them out there in the market. I've been involved in the development of a uterine balloon that I have no financial interest in, but is now produced in India by Pregna in Mumbai. And they're really a superb organization with, they care deeply about women and have been donating, and they make essentially no money on this. And it's a US FDA approved device. But there are other excellent balloons out there, the Bakri balloon, and there are balloons from South Africa, and there are Rausch balloon. There are other balloons. It's really not that important as to which balloon, as long as it's a quality balloon that has regulatory approval. But it's important that a balloon is placed early. That's the really important thing. There's some interesting research that's a bit ad hoc performed in Nepal as well as in Maharashtra, which was actually placing uterine balloons prophylactically in women that are profoundly anemic. And there isn't really scientific data other than anecdotes of success. So I think we have more to learn, but I think I have seen many women and I receive a WhatsApp text about a woman's life being saved with a uterine balloon 3 to 5 times per week, every week for the last 5 years. And that is because the uterine balloon is placed in a lower level setting and a woman's hemorrhage is arrested. And that's, of course, almost entirely from atonic uterus is where it finds its place.
Oh, fine. Before we end this interview, one last question. I happened to read one of your articles, which was a very nice article about role of ketamine by non-service providers, that is by paramedical workers. It was a very interesting article. Why I'm asking this question, Dr. Burke, is because if you see around the city, the availability of a qualified anesthetist is good. But if you go, say, 50 kilometers beyond any city, anywhere in India, the availability of the anesthetist is very low. And, it takes a lot of time to call the anesthetist, especially when the patient is in second stage of labor, or if she is into PPH, and then calling her and getting things arranged. It takes a lot of time. So the golden hour is lost. So I really want you to tell all of us about the study which you are doing about role of ketamine, how it can be administered by even a paramedical. Because, in our settings, many a times, even the doctor is there, a nurse is there, or some other functioning doctor is there who can easily administer ketamine, and the doctor can do the C-section in the appropriate time. So, but because of lack of anesthetists, many a times there may be maternal mortality, perinatal mortality, a very high incidence of babies being transferred to NICUs, fetal distresses occurring just because of lack of anesthesia or delayed C-section. So if at all you could throw light on this particular paper of yours, we really will be happy to hear your views.
Thank you for asking. I embarked on that research because of the same reason, is that in many places in the world, not just in India, there is a lack of anesthetists when needed. And in many places in the world, there are doctors that can do cesarean section, but there isn't an anesthetist in a timely fashion. So the consequence, exactly as you said, prolonged labor. So you have an atonic uterus and a mom is in trouble with PPH, obstructed labor that ends in all, sepsis, maternal death, newborn death, or newborn, damage for that lasts for a lifetime. So I've used ketamine personally in my practice in all sorts. I've done splenectomies. I personally have conducted craniotomies using ketamine. I've done a lot of work using ketamine, easily 5,000 or 6,000 cases
Wow.
And it's common, if you look in the literature, it's been around since 1961, and it's used. It's been used by militaries. It's been used in humanitarian crisis zones and earthquakes in order to operate safely on people. It's used all over the world, but there isn't really a properly regulated clinical pathway for use in emergency surgery. So we developed a very simple 5-day training program, and initially in Kenya, and it's now spread to 17 countries. This package is very straightforward, and it is essentially use of ketamine at 2 milligrams per kilogram, IV, slow bolus over 40 seconds, and then it's monitoring, providing oxygen, providing IV fluids, and things that a nurse or a non anesthetist can actually do quite easily and learn quite easily. You know, ketamine causes an increase in blood pressure, slight increase in heart rate, increase in minute ventilation, which is fantastic. You don't lose your airway unless you give it very fast. You shouldn't, which you shouldn't do. Give it over 40 seconds, 30 seconds. There's a very rare incidence of laryngospasm, but you can easily break that with gentle bagging through 2 people holding. That happens about 1 in every 1,000 to 2,000 cases. You can get laryngospasm, but you can bag right through it and it breaks within a minute or 2. It's extremely safe. We now have over 2,600 consecutive cases recorded of emergency operations, not just cesarean sections, but major laparotomies and other operations. And it's only triggered when no anesthetist is available in a timely fashion, and the woman that needs a C-section is at risk, or some other emergency operation. I'd be thrilled to bring this to India if there was a pathway that was in. If you or if anybody wanted to really explore this further, this is something that I would specifically bring the team and come to India and work with you on.
Thank you. Thank you. Yeah, we really would appreciate that, because, you know, that is the problem. If at all you go to all the peripheries of peripheral societies of Maharashtra or anywhere in India for that matter, availability of the anesthetist is really a big issue. And that is one of the leading causes of high incidence of C-section as well as high incidence of perinatal mortality and morbidity. So anyway, we would definitely like to work with you on this particular aspect and the role of ketamine. I mean, as a matter of fact, if at all you could have a task force of about 8 or 10 people, anesthetists who will train all the paramedical staff. Okay.
Yes.
More useful for us also. I mean,
let's do it.
Yes.
Yeah. I mean, really, reach out to me and let's do that.
Sure, sir. Sure.
Okay.
So, yeah, I guess we have taken 40 minutes of your Boston morning. So thank you so much for that. And I really appreciate you coming to India and giving us this particular PPH bundle approach via FIGO. So thank you so much. And we all will be always indebted to you for your guidelines on this issue. Thank you so much.
Thank you. We teach each other. We are all brothers and sisters. Thank you, everybody.
Thank you.
Thank you so much once again, Thomas Burke sir and Kiran Kuthuti sir for this wonderful session. Sujata Darvi madam had just joined. So it's my great privilege to welcome our respected Secretary AMOX, Dr. Sujata Darvi madam. Madam, are you there? Madam is not there.
Madam is not there.
Okay. Let's move on to our next session. Next slide, please. We have again esteemed faculties for this session. The speaker, respected Dr. Sheila Manya madam, Vice Chairperson elect ICOG, and we have respected Dr. Surekha Tade ma'am as an interviewer. Next slide. It's my great privilege to welcome and introduce my mentor, my guide, the most dynamic woman I have closely seen, closely observed, that is Professor Surekha Tade, madam. Madam is currently Professor Unit Head at JNMC Savangi. She is President Vidarbha ISOPA, President Devi Savangi Society, Chairperson elect Foxy Clinical Research Committee. So much to say about her. She is mentor to many students, have high grade of clinical research attitude and involved in so many community projects. I welcome you, ma'am. And I request you to please introduce our speaker for today. And hand over mic to you, ma'am.
Thank you very much, Jaya. And why is there an echo?
No, ma'am. It is clear.
Is it fine? Yeah.
Yes, ma'am.
Thank you so much.
Yes,
And at the outset, let me thank the High Risk Pregnancy Committee of AMOGS and all the AMOGS office bearers, the President, Dr. Rajendra Singh Pardesi, sir. Then we have Dr. Kiran Koti here, who is the Vice President. We have Sujata Darvi, ma'am, who is the Honorary Secretary. And we also have our chairperson of high risk pregnancy, who is the key person behind organizing these PPH the series, Dr. Ashmi Kahar. We also have Dr. Jaya Turaskar here, who is the convener. So my heartfelt thanks to all of you for arranging this very beautiful interviews session. And we have, after the beautiful and wonderful interview between Dr. Koti sir and Dr. Thomas Berg, now we are here to listen to a very wonderful persona, we must say, none other than Dr. Sheila Mane, ma'am. It's my proud privilege to introduce her. I mean, it feels wonderful that maybe I feel proud myself that now I'm sitting across in a forum where I can interview Madam, because she is so well known not only across India but globally also, and specifically about her work, which she has done so dedicatedly for saving maternal lives, specifically regarding postpartum hemorrhage. We all know her as the PPH lady, and she has gained that name by more than 30 years of dedicated work which has done for this particular issue. Madam is MBBS, MD, FICOG, FIC, MCH, and she's also a DNB faculty. Apart from that, she is the ICOG Governing Council member, President of ISOPARP Society of Bengaluru, Menopause Society, also she is the President. And we are very, very proud, Madam, that you have been elected as the Vice President of ICOG, and we are very much eager to, we look forward to the work you will be doing as the ICOG Vice Chairperson, and you are known as the PPH lady for more than 2 decades of work for Foxy. Also, Madam is the national facilitator for adolescent health in WHO, and she has received the Best Teacher Award. Welcome, Madam, for this interview on the platform of High Risk Pregnancy Committee of AMOGS.
Thank you, Dr. Surekha, for that kind introduction, and thank you so much for making me a part of this very innovative program, that is advocacy. And as learned a lot now, even from Dr. Thomas Berg, but Dr. Kiran Koti was interviewing him, and we know that he is a stalwart among us. So thank you once again for inviting me. I would like to thank High Risk Pregnancy Committee again for inviting me for this AMOG's prestigious meeting, particularly for the advocacy on postpartum hemorrhage.
Welcome, ma'am. Welcome. अबला नारी तेरी यही कहानी, आंचल में है दूध, आंखों में है पानी. It's been 100 years now that work has been started, to save mothers and, do something about the lives we have been losing to childbirth and delivery. Madam, your passion for training health professionals in postpartum hemorrhage management is very well known throughout the country. You have been You are being known as the PPH lady for the trainings you have conducted through so many years. My question to you is, how did you pick up this topic as your life's work arena?
I think my journey started in Foxy when I became a member of a Safe Motherhood Committee of Foxy. And those days, the chairperson post used to be for 5 years. Okay. And that time, the main focus was on anemia. Okay. Because I was with Dr. Shirish Patwardhan, and you know that anemia, chale jao, anemia, hatao, these were our slogans. And we worked very hard for awareness as well as with the obstetricians to see to it that we really work towards that. Then as a president, I worked towards adolescent health committee with the adolescent health committee and for the adolescent health, where also again we looked at the anemia part. Then I became a Safe Motherhood Committee chairperson, where I concentrated more on emergency obstetric care. And in emergency obstetric care, the PPH is on the top. We know that maximum mortality is due to postpartum hemorrhage. So along with my colleagues at Bangalore Society, I had an opportunity to create a module. Then we also created a simple emergency box, a PPH box, a eclampsia drug box, okay, as it was emergency. And also for the sepsis and all other causes for emergency obstetric care. So my journey started there, and then I became a chairperson. That was 2008. In 2009, in Cape Town, I had an opportunity to meet Professor B. Lynch. Okay, Dr. Bellad introduced me to Professor B. Lynch, and he expressed that he has the mannequins and he would like to come to India and conduct these workshops. So there my journey for PPH started. Along with RCOG in Bangalore, I did my first PPH workshop as a Safe Motherhood Committee chairperson with Professor B. Lynch. And it was really eye-opener. In that, another important part, apart from the surgical treatment, was the blood loss assessment, which we have really not given so much of importance, because unless and until we diagnose PPH, we know the class of hemorrhage, it is very difficult to manage. So Dr. Mahantesh accompanied him, and Dr. Bellad was also there, and Professor B. Lynch himself. So we had a big gathering. It was, I never expected, there was no place in the hall. So we had to prepare a uterus out of some sponge, put it in one bag and give the suture material. And because he could give hands-on to only 25 people, so everybody looked at the video and everybody sitting in the hall practiced that. Okay, but apart from that, we also had deliberations on the medical management and all that. So my journey, passion for PPH started there.
Very wonderful to know your journey, madam. And then at the outset only, if you meet people like B. Lynch and also support from wonderful teachers like Dr. Ballard, I know that your journey would be successful, and you have proved yourself and you have inspired so many youngsters, you know, through your trainings. One thing which mesmerized me when I looked at your trainings and when I looked at your videos which you have prepared for training of, and I have seen those on YouTube also, was the wonderful, the uterus which you have prepared from the woolen, threads, the wool which we say. And I always think that the way you used to show B-Lean suture on that, it was really wonderful, and we the trainees can really nicely understand. I would like to know from where you procured those wonderful mannequins made up of wool. And once I have asked you also to lend me, but let me know where from you procured them.
I'm at it. Yeah. So that video, I could organize it. One of the suture material company, I must tell here, that is Healthium, and that model is just like what B. Lynch, Professor B. Lynch had brought it. So we tried to do a replica of that. So there is one taluka in Karnataka where there are some Nepali families who are staying for a long time, and we know that Nepalis, they are very good in knitting. Okay, so through that company, we could approach them And then we requested them, and we saw the first model, and they really did a good job. So we got it done from them. But now, as many requests are coming, so I have again approached, and I'm trying to see that if I'm able to give that model, not only the people, those who are asking me, but every institution and every health facility where we have to teach the health workers, that will be my next aim, to get it for everyone across India.
Thank you very much, ma'am. Now, so much training is happening, regarding PPH. We are seeing Dr. Preeti Kumar also doing such wonderful work in so many states. We are seeing that we are trying to train healthcare professionals, but still, in spite of the work being done by so many stalwarts and so many teachers, we are still finding that this menace of PPH is still ongoing so much that we are finding one death because of PPH every minute. And that's devastating as far as maternal mortality is concerned. Now, my question is, what do you think is lacking? What should be our thrust areas, and what do you think is missing in the whole link, and why are we not able to address this issue as and prevent the maternal mortality because of it?
You rightly pointed out, Surekha. I think if we know about the medical management, and I think Professor is here, and we know that we should not allow the patient to go into refractory PPH. So the early resuscitation matters a lot. Okay, and in our teachings, now we have to make people understand that they have to use anti-shock garment, they have to use balloon tamponade, okay, so that, to prevent the blood loss, because unless and until we are training people, it is not only the training, even if people are aware, still so many people do not have this anti-shock garment in their institutions, or even very less in private sector. Now, private sector cannot be neglected, and I'm really happy that what Dr. Preeti is doing, she's trying to train the private health sector, because, they are again away. Now, if we look at the government now, because of the Laksha initiatives, as we have the SOPs and we have still
And then you have
not
muted.
well
Yeah.
not well equipped. Okay, so I know it is the accountability. Now there are audits happening, everything is happening, but still PPH is on the rise. And another reason for that increase in the incidence of cesarean section. We know that the incidence of cesarean section is on the rise, because with vaginal delivery, the incidence of PPH is only 2 to 4%, whereas it is more with cesarean, and that is about 6 to 7%. And if you look at the litigations in India also, it is maximum for PPH and maximum for PPH during cesarean section. Overall, yes, the maternal mortality rate is coming down. I know Maharashtra and South is doing good, but every facility, unless and until there is an audit and there is accountability, the resuscitative measure index
And then
is
you have muted
because
yourself. Yes.
in class 1 and class 2 hemorrhage, the patient is still stable, and people think that the patient is stable and then she goes into class 3. But if we have taught everybody that they have to calculate the shock index, it will be very easy. I must share, recently we had Professor Arul Kumaran coming to India, okay, and he gave me a homework. He said, there is that global monitor, the cradle monitor, to monitor the blood pressure, which also tells us about the shock index. Okay, but it's not predicted there. And I think now there is a necessity for us to give these type of equipments in periphery, where people will know, because, clinical blood loss assessment, yes, but how many people are able to do that? So if we have these type of that cradle BP apparatus with a monitor, like a traffic signal, if the blood, it shows the green, it is normal. If it is yellow, that means it is warning you. And if it is red, that means the patient is in shock. So it tells you about the low blood pressure, as well as it also tells you about the high blood pressure. And if we are talking about postpartum hemorrhage, it is it can tell you that the patient is in hypovolemia, and if her blood pressure is low, definitely the health worker will be able to shift the patient earlier, or at least they will be able to start the resuscitative measures early. So this is that VSA monitor where there are traffic signals like thing will appear and it will be very easy. Now, all of we know that the study was done again in Karnataka. That's the CLIP study, where they had given it to the periphery and they tried to see that how many people reached their facility in time. And they found out that more than 200 patients who were not coming early were sent or referred to the tertiary care center. So I think these type of monitors, I'm just trying to implement it in Karnataka right now, because again, the postpartum hemorrhage is a concern. But slowly we will have to see, we will need a study to see that how helpful it is. So basically, it is very important to talk about, to teach about blood loss assessment and the early resuscitative measures. So a simple thing, we try to tell now, you also know about Laksha. Once the patient pulse rate crosses 100, you have to immediately start her, giving her isotonic solutions, have a 16 gauge cannula, and all the successive methods, uterotonics to be given by manual compression. So repeated we have to do. It is not that we have trained them every 3 months. There has to be a drill to be conducted, because the staff might keep on changing. In private sector also they change, and we will have to train them repeatedly, and also to see to it that we are assessing them, which is happening now through Jeevan Dhara, but we will have to do it all over the country. And we know that WHO is conducting that E-motive study. We know the professor told us about the tranexamic acid. So that E-motive study is again has come up by WHO. That is the answer for your question, that why we are still losing mothers. That means there are two lacunae. One is,
Madam, you have muted yourself.
yeah. Okay.
Yeah, thank you, ma'am. So the take-home message, I think, from this is that early diagnosis, first of all, that means rapid initial assessment of the patient, and being alert that yes, this patient has started losing blood, and before she goes into a more worse situation, we need to diagnose early. That means we need to have some key tools where we can measure the blood loss, because whatever we visually see, that blood is an underestimation of what already the blood has been lost. So I think that is the key area of work which we need to address, so that we can pick up the case very early, and you start instilling the PPH bundle in such a way that the patient, you start the arrest of the bleeding occurs there only. So as you have said about tranexamic acid, and Dr. Park was also discussing about it, mostly what it has been advocated that it should be used after, within 1 hour after the patient has started bleeding. Now, what about its prophylactic use? What do you think? I mean, have you used it prophylactically, and do you think it would be very much beneficial as a prophylactic drug?
See, now still the Cochrane data does not recommend it, but there are studies. There is one study I remember which was done in AIIMS, Delhi, where they have used it prophylactically, particularly in the cases of cesarean, and they did find that the blood loss was comparatively lesser when the tranexamic acid was used prophylactically. Okay, so definitely it makes it. Now in my practice, I think at least in high risk cases, I am using it prophylactically, and I do find that definitely it makes a difference, like particularly in high risk cases. So I know, and we know that there are more studies which are going to come now. There is another study which is going to come where the tranexamic acid is advocacy is that to use it in every anemic patient.
Anemic patient.
Use a lesser dose also. We can use only 500 milligram, not 1 gram, prophylactically for all the anemic patients. I think that is the another study which is going on. And I think for a country like us, it is very important, because the definition of postpartum hemorrhage in an anemic patient is very different. They are small made. So if we look at the blood volume, even if her blood volume is less, And even if she loses 350 ml, her blood volume may be only 3 liters or 4 liters. And if she loses that much also, she can go into hypotension or hypovolemic shock. So we have to look at that. And I think definitely we are waiting for that to come. And tranexamic acid, hope it is available, easily available. Theoretically, they talk about the complications, but still we have not come across. I think it can be really safely used. The chances of VT, theoretically it is there, but practically we have really not faced the problem. So yes, I think
I'm
it
glad
can
to
be
share,
used
ma'am,
prophylactically.
that this year, I'm glad to share, ma'am, that this year I have given tranexamic acid as a prophylaxis in cesarean section patient as a thesis topic to one of my students. And
Good.
we will definitely, it could be a local sort of a generation of evidence so that we can start using it without fear. No, I don't think there is, we have seen any side effects as such, but we would like to know whether you start using it prophylactically. Now, Madam,
we can
my
also
question,
use, Surekha, can I add something? We can
yes,
also use it intramuscularly, half a dose, 500.
Yes.
Can be given even intramuscularly, because if some health workers are not able to, okay, yeah.
Secure, if they are not able to secure an IV line, probably that is what we should work on to generate some evidence for its use. Madam, I have come across quite a few times. I have seen events where multiple, utrotonics are being used. So if the patient starts bleeding, what happens? Patient, the doctor who is attending the patient will start oxytocin drip, then they will give the ergometrin, they will also insert the parectal misoprostol, and I have seen that carboprost also has been given at the same time. Still, many a times the arrest of bleeding doesn't occur. So what do you think about this? Many a times we don't even understand what drug and what dosage. So is it right to give all the utrotonics at the same time? And what do you recommend, ma'am? I think that's a very practical question.
Yes. See, if we say, suppose if we are conducting a normal delivery and we find, okay, the first thing is to add oxytocin, 20 units to 500 ml of RL, okay? But you also have to do the bimanual compression and rule out traumatic PPH and all those things, concurrently. Yes. After starting the oxytocin drip also, most of the time, if it is not controlled, at least now as ergometrin is not being used so much, yes, we do use carboprost. I think if the patient is bleeding profusely, we can wait only for 5 minutes, but not more than that, because we know that the patient every minute she is losing, okay, in PPH. So at least our strategy is that we use carboprost, okay? And most of the time, the number of injections what we require to use is not more than 2. We use 2, and by that time, if it is going to respond, it will respond. But there are situations where the patient do not respond to this, okay? In that case, we will have to really reassess the patient. You have to think that this patient's uterus is still remaining. Yes, now we can give carboprost repeatedly. Yes, every 15 minutes or half an hour will remit. But apart from that, we will have to also assess all other factors. Now, giving misoprostol along with that per rectally is again, like most of the time what we do, because it again holds on to the uterus for a longer time. But I think in my practice, if I'm using carboprost, I would like to wait and see. I don't immediately give misoprostol, okay? Because it also acts on the lower segment bleeding. Now, what we see during cesarean is sometimes the lower segment bleeding. And if the carboprost is not there, ergometrin still remains a good choice, because it will contract even after a normal vaginal delivery, upper segment as well as the lower segment. So giving one dose is not going to cause any harm. We can give, okay, because carboprost is not immediately available, and then we can give carboprost. Oxytocin will be on flow. So I think that need to be practiced. We don't have to immediately go on giving everything, because we will have to wait and see. And I think 80% of the time, the medical management, more than that, works.
Respond.
Yeah.
And definitely, madam, those 20% who do not respond probably need more a procedural,
Yes.
management. Probably she will need a bimanual compression and other procedures need to be. So we quickly
Yeah,
need
that
to
has
think
to happen
whether this
concurrently.
patient is going to respond to your medical management or some other procedure needs to be done for this patient. Madam, there is
Yes, very true.
is a case scenario I would like to put forward in front of you. A patient who is in the periphery is landed into PPH. They have tried to do the primary management, but the patient is not responding. Now, the patient needs to be transported to a tertiary care center. What do you advocate that should be the procedure when you're transferring this patient? And how do you ensure that this patient reaches alive to the tertiary care center?
See, one thing is all of us, we know there has to be two number 16 gauge cannulas, and the IV fluids is on flow. If they are able to assess at least 1:3, the fluid should be there and it should be on flow. Anti-shock garment in place. And if the people are trained, they should put the balloon and refer the patient, because actually it is the blood loss. Okay. And if a competent health worker is going to accompany, I think it is better we send somebody, a competent health worker along with that, okay, along with them, who can also go on doing the massage in between. Even we can do it with anti-shock garment also, okay. If there is a traumatic PPH, I think we will have to pack the vagina very tightly. Tranexamic acid will be given, no doubt. Uterotonics will be on flow, and first nearest facility, find out the person is available there, find out that she's going to be a near miss, immediately she's been taken to the labor room, because it should not happen that after she reaches the facility, there is a delay, because that can also happen. Okay. And if the blood is arranged, I mean, if they are able to arrange, at least that also can be transfused. If the PRBC is available, because sometimes it could be a taluka place where the anesthetist is not available and they're not able to do. So it could be a transfer from a PSC to CSC. From that should be in a class 1 and class 2. From CSC again to tertiary care center will be a class 3. Okay. In class 4, you will have to resuscitate her there and then send. So it's very important that the blood storage facilities are there. At least the patient receives 1 or 2 PRBCs, if not the other blood products. And then she's been referred. Yes, oxygen on flow, IV fluid on flow, a able attender who can understand the seriousness also.
Madam, this when I was working, we were working with Dr. Burke on this program about UBT. This was what was called as a vertical integration. You integrated the periphery with the next center where you have to refer, and then again the tertiary care center was also identified, so that you have a chain where the patient can be referred.
Yes.
And we also had this helpline created in each labor room, wherein
Yes.
this helpline was shared with the peripheral centers. So
yes.
On that helpline, the peripheral center person used to call the topmost person, like the professor or the unit in charge on duty, would immediately know that such and such patient is bleeding in the periphery and she is being transferred from Hinganghat or RV to Wardha, and we used to immediately alert our labor room that such and such patient is coming to you. So I think that kind of vertical integration and forming a chain
Yes.
in between the periphery and the tertiary care will really help when you are having this. And of course, what you have talked about, the NASG has to be taught and available, and at each and every center, we need to ensure that the government provides these NASGs at the periphery, and definitely the UBT, if you have inserted during transport, that would also work. Madam, another scenario, now the patient has reached the tertiary care and she is bleeding, she has bled a lot and she has been taken on the table, and now you have to make the decision whether you do a hysterectomy for this patient or whether you would like to do an internal ILAC. So internal ILAC ligation also being propagated so much. What is your take on it, ma'am?
It again depends on the expertise of the surgeon and the general condition of the patient and the availability of the blood and blood products immediately. Whether she's in class 3, she will require massive blood transfusion. Okay. Meanwhile, that should be arranged, and any given time within 10 to 30 minutes, we say it should be available. But if the patient is really in shock and we have to save the life, I'm very sorry to say that in so many places, the people are not confident of doing internal iliac artery ligation, or if they wait for the expertise to come, then they have to do a hysterectomy, because at least we have to save the life of the mother, because she is in a very critical condition. And internal iliac artery ligation, there is no guarantee that it is going to save her. Another thing is we have to see whether she is gone in for DIC. Because if the patient is gone in for DIC, okay, then again it becomes very difficult to save her, because we will need massive transfusion. Even doing a hysterectomy for DIC patient is also very tricky. I would like to share one here, that recently, one of the company has come out now with fibrinogen in India, and they came and gave me 5 ampoules, 5 vials of fibrinogen. And I was surprised that day to see that will I get a chance to use this. And in that week only, we had a case of abruptio placenta. Okay. And we know that in abruption, the hypofibrinogenemia happens very quickly. So I had an opportunity, because we ordered for the blood products and everything, but we used fibrinogen in these patients. Her hemoglobin had dropped to 5 grams. By the time everything could come, we gave her and we could save her. There was another patient who was referred again, abruptio placenta delivered vaginally with hematuria. Okay. Yes, we still do clot observation test. We gave her 2 grams of fibrinogen, and within 20 minutes, her hematuria was corrected. Okay. So I know it is not possible everywhere now. We have to give plenty of blood transfusions. So another patient who had a maybe you can say that subclinical amniotic fluid embolism, who kept on bleeding. We had to keep the balloon for a longer time, even for 72 hours. We gave her multiple transfusions. She had a liver ischemia also. Her INR was so high. In that case also, we gave 4 grams of fibrinogen. Okay, we are in Bangalore. We can, the patient was also affordable. She had already received massive transfusion. So I know it is nowadays what we are facing is very critical patients. The scenario is changing now, even in PPH. We are getting patients with jaundice. We get patients with multiple problems. And, unless and until you have a blood bank where you can initiate MTP, that is massive transfusion protocol, and get all the products, it is very difficult. So in this situation, if she goes to a district hospital where the blood bank is there, but you don't have a person who can do internal iliac artery ligation, or not confident, you have to save the patient. I think hysterectomy will at least.
So that was what I wanted to give as a key message, that many a times there may not be an expertise for internal iliac ligation, and we should not hesitate to do hysterectomy, peripartum hysterectomy, to save the life of the patient. So that is what I wanted to really give a message. When needed, you need to think of the life first, and the technical expertise may not be there. So let us think of situations where you have to do what's need to be done. So we should be taking decisions quickly, and that is what the training is to be needed about. So we are coming to the fag end of our interview, but I would like to ask you a very, very important question. Now, there is a private practitioner, and she wants to make her clinic PPH proof. How do you suggest she should go about it? The private practitioner is sitting here, Dr. Jaya Tulaskar.
Yeah. See, the private practitioner, if she wants to make it nobody can make it PPH proof. I think at least we have to see that there is a less morbidity and no mortality. Okay. So prevention comes first. So let us build the hemoglobin in her body itself. So anemia, antenatal care where anemia correction is done, and the patient is a high risk, or she is a Rh negative. And every private nursing home should have a association or accreditation with the nearest blood bank, where they will be able to send you the blood and blood products immediately. Because it is very important that immediately, for example, I have Alliance Blood Bank, and who will, if I say Sheila Mane here, they definitely oblige, and I really thank them for that. Okay. Now we have to sensitize our obstetricians to tell them that in case of an emergency, if your patient is in class 3 or class 4, ask for O negative blood. And we have to also sensitize our blood banks to keep that, and meanwhile, then you can give the group specific blood. But to see that, to make it PPH proof, your staff need to be trained. They should also know the measures, what need to be taken, the vitals, to be monitored and immediately. So, the obstetrician has to see to it that her health workers are also trained. Okay. You also have an anesthetist who is there to help you. You have a team, you have a task force. So I always say that that is my real treasure. In case of an emergency, when I make a phone call, if immediately within 15 minutes, 3-4 people come to help me, that is my treasure. So we should have a group or a group practice where in case of problems, we help each other. We take each and everybody's help. We have an oncosurgeon in our team, even in private particularly, or a urologist who can come and help you in case of an emergency. Another thing is the availability of the drugs and the other. I think today in India, all the private hospitals are aware. Many are Manyata accredited. They also know. I would like to put a word here, like now carbetocin is there, which is heat stable. And we do find that the blood loss is definitely compared. Yesterday, I operated a case on placenta previa, where I used it and I really found that the blood loss was definitely lesser in this after using the carbetocin. So I think we have to really see to it that they should also go for accreditation, so that there is accountability and their staff members are trained. They have anti-shock garment. They know how to put the balloon tamponade. They have their team in case of an emergency who can come and help them immediately. And if they are not, they should also have an attachment with one tertiary care center. If not possible to manage here, they may have to shift the patient to that place where the patient may require massive blood transfusion or uterine artery embolization or other higher things. If they are in district place, at least we know if the blood and blood products, immediate decision to do peripartum hysterectomy, which you were telling. Okay. So
That's
that
wonderful,
should be
ma'am.
done. So I think the training.
Madam, I want to read out life's last message of one obstetrician to you. I love my husband and children very much. Please do not trouble my husband and children after my death. I did not commit any mistake and I did not kill anyone. PPH is a severe complication. Stop harassing doctors for it. This is the message written by Dr. Archana Sharma when she committed death on suicide, when she did each and everything possible, but the patient could not be saved. Madam, how do you think we can stop this harassment, and what do you think our organizations like ICOG and FOXY can do to prevent this harassment of doctors?
See, now, unless and until there is a awareness among the public, but still we know it's on the rise. But first of all, I think we have to be really strong. If we have to be strong, we need to talk to people, we have to convince them, and alone we can't do, because when we are handling an emergency, our moral is a little low. So we need more people. I think at least if she could have consulted or she could have contacted some more people, because, the people's attitude is not in our hands. And, it is happening everywhere in India, but the awareness, I think, now when we are doing the antenatal checkup itself, I think we need to do counseling for the mother, for the patient's mother or husband. At least once we should talk to them and see to it that if she is our regular patient. But so many times we get unbooked patients also, and she was practicing in a remote area where she has to accept, she can't say no to that also. So all the facilities may not be there in that place, but one need to be strong in those places, and you have a strong association. IMA can help you, our own federation people, those who are there practicing in the same area should be called immediately. And, whenever these scenarios happen, we have to learn to go away from the scenario. I know it may happen, looks like a cowardly or nothing. I have faced the situations. Even in my hospital also, not my problem, but surgical problem, but you have to be very bold. Once they know that you are bold, they definitely try to change. But these type of harassment will go only when we strengthen ourselves and we come together. Unless and until we come together and we see to it that these people also face some punishment or something, not exactly the punishment, but they also should be alerted that they cannot go on troubling or harassing the doctors, because it's not so easy, and they also should be taken for task. I think we need to do more and more.
Yes, madam, absolutely. And unity, I think, is our strength. We need to be together. There have to be more Sheila Manes. There have to be more Preeti Kumars and more Surekha Taidis, I think, working here, Dr. Jaya here. So that we can come together and keep on advocacy and keep on training, and probably we will reach a time where probably we may not be able to stop PPH, but definitely the morbidity and mortality can be reduced to a minimum. With that note, I would like to thank you very much for being with us on this forum and sharing your wonderful knowledge and advocacy and trainings and awareness about this very, very important issue of PPH. Thank you very much, the conveners, and thank you very much, the HRP committee chairperson, Dr. Rashmi Kahar. Thank you.
Thank you, Dr. Rashmi, for giving me this opportunity. It was really, and Dr. Surekha, you yourself, you are a stalwart, and I know that the maternal mortality of Varda has really been come down. Whatever vertical integration which you have told, and I'm happy to say that I had an opportunity to meet Professor Thomas Berg in our annual conference at Bangalore, and thanks to Dr. Poonam for that. And happy to see that the PPH bundle is happening in many parts of the country, and will definitely able to strengthen both public as well as the private sector, because our private sector is also very large and we cater to many, many, many antenatal mothers. So all of us will have to strengthen ourselves and see to it that we try to save the mothers from PPH, which is a preventable cause. As it is preventable, we have to prevent it. So preventing the preventable is the mantra. Thank you.
Thank you so much, respected Dr. Sheila Mane madam and Dr. Surekha Taide ma'am, for such a wonderful, elaborative and full of practical things session. We are very much honored and lucky to have you both here, ma'am. And ma'am, I'm practicing in a small town, it's Singangat near Wardha. So since long we are using tranexamic acid, ma'am, preoperatively to the patients. Almost all high risk we give half a dose, and previous time we give 1 gram. We have never encountered any side effects, and blood loss is decreased, and it is really helpful. Thank you so much, ma'am, for such a great messages you both have given. Thank you so much for being here, ma'am.
Thank you. Thank you.
Now, moving on to our last session. For last interview, we have respected speaker, Dr. Preeti Kumar madam. Madam is chairperson FOXY, Safe Motherhood Committee, and we have interviewer as Dr. Anil Sakre sir, is chairperson AMOX chairperson of Vaginal Surgeries Committee. Next slide, please. I'm honored to introduce and welcome Dr. Anil Sakre sir. Sir has been ex-associate professor in Department of OBGYN, Dr. SC Government College, Nanded. He has worked as assistant professor at GMC Nanded for 11 years. He has been faculty at various national and international conferences. There are 19 scientific publications. He has contributed in Williams textbook of obstetrics as well as operative obstetrics by Cunningham's. I welcome you, sir.
Thank you, Jaya, for the nice introduction.
I request you to please introduce and welcome our speaker for today, sir.
Yes. I once again thank, at the outset I should thank Dr. Rashmi, Dr. Jaya, even our AMOX president, Dr. Rajendra Singh Pardeshi sir, AMOX Secretary Dr. Sujata ma'am, I'm a Vice President, Dr. Kiran Kotukoti, for giving me the opportunity on this dais. I'm really thankful to all the conveners, especially Jaya, Rashmi, Chaitanya, all the conveners of this wonderful activity. And I really congratulate to all the conveners for doing such great activity on the AMOS platform. And I am privileged here today that I am taking the interview of a person who is doing a substantial job as a chairperson, Safe Motherhood Committee, Foxy. She is doing since day one. I personally know her. I am working in his committee also. So I know the pattern of the way she is working, how she is working, the challenges she faced, the output she has given to the public, and all the things. So it is my privilege to introduce Dr. Preeti Kumar ma'am. She is a co-chair, Maternal Perinatal Committee, SAFOC, chairperson, Safe Motherhood Committee, Foxy, committee member, FMM Committee, AOFOG. She was organizing secretary, UPCOG 2023 Lucknow, AISOG 2020 Lucknow, Justices 219 to and 2019-2018 IAG, NZYF 2017, which was at Lucknow. She is Vice President, Lucknow Obs and Gynae Society from year 2020 to 22, and she is a core member of Prevention of Violence Against Women, Sale of Foxy 2021 to 23.
Anil, I think we should proceed on with the interview.
Yeah. It will
Thank you
take
so
half
much.
an hour. It will take really half an hour to read all your bios. But a fabulous work and fabulous representation
so
at
much.
various chairs on national and international level. I
Thank you.
welcome you, Pritam ma'am, and it's my really privilege to interview you on this dais.
Thank you so much, Anil.
Just many of us know, few of may not know the way you are working, the work you are doing. Rather than all other previous two giant speakers, Dr. Thomas and our Dr. Sheila madam have talked on the clinical aspects, and rather than going on a clinical aspects, training part is also very important part to prevent maternal mortality. And you have chosen the such an area, particularly the northeast region of our country, to reduce the maternal mortality in that area, and you have made a target to all the particularly the private practitioners to reduce the maternal mortality in that area, and we really congratulate you for your this substantial work. My first question: Can you throw light on the work done under Safe Motherhood Committee, Foxy, which is done by you?
Thank you so much, Anil. Let me thank the organizers first. I have high regards for Dr. Rajendra Singh sir, and definitely Dr. Kiran and Dr. Sujata. I think they are the people who keep on, encouraging my work all the time on all the groups. So thank you so much. Thank you, Jaya, and all the conveners. And special thanks to Rashmi for inviting me here on this forum. And I would really like to congratulate the committees which are involved in this advocacy webinar, that is HRP, Emergency Obstetrics and website, and of course, Amravati Society. Anil, I must tell you that maybe in next 25 or 30 minutes that we have, I just want to put on record that every member of Foxy, maybe he may be or he may not be a chairperson, but that they can take the legacy forward. They can do whatever they want to do. So, this story, the history of doing the work for the PPH started in 2020 when I organized AICOG. And here the meeting was organized with Dr. Thomas Burke and the government of Uttar Pradesh, that since the mortality is high and PPH contributes to large chunk, let us do a pilot project in UP. So I was made the society liaison officer in 2020. And we were supposed to do the training of 10 public facilities. 5 were linked to KGMU here in Lucknow, and 5 were linked to Varanasi, BHU. We got some funds from FIGO. Foxy got some funds from FIGO, and UP government supported this project. And this was Foxy FIGO PPH project. So we started, because of the COVID, we could not start this. We started off in 21. And I was made the society liaison officer. I was a link between the Foxy, FIGO and UP government. And I used to, collaborate with all three and make this training happen. So first we were made the master trainers. And after the hectic, all the trainings online and on site, we became the master trainers for PPH. And then we started working for these 10 facilities, public facilities. Then what happened is suddenly I got a call from Dr. Hema Diwakar that Preeti, my sister Anu, is in Pathfinder International and she has 200 NASGs. So can you use these NASGs under Safe Motherhood Committee? And in the meantime, for the society liaison officer, my job was to disseminate this PPH bundle approach all across the country. So I thought better I should use these NASGs and start training the private facilities, because the public facilities were already on board. So I, took some facilities from UP, some from Jharkhand and some from Bihar, because they had high maternal mortality and morbidity due to PPH. So initially, then I started these trainings, and, one by one this happened. I think there's a destiny for everything. Pathfinder donated NASGs. Then I talked to Dr. Thomas, sir, I want to just disseminate this to all over the country. And I have selected 3 states for going ahead. So he said, Dr. Preeti, I will donate 200 ESM UBTs for the training. And then Jepaigo came forward and they said, Dr. Preeti, we will provide you the link, Zoom link. Then UNICEF came forward that we will provide you the IC material, information, education, and communication material. So there was no funding at all for this project. And we coined this word Jeevan Dhara. And these were all dissemination of PPH EMC bundles in 3 states, that is UP, Bihar, and Jharkhand. Then when Pathfinder International, the NHSRC also, the government, Dr. Himanshu Bhushan also came forward that we will also support this initiative. Believe me, there was no MOU with Foxy. It was just a mail communication. And all the leading organizations of a country, international organizations, they were on board. Then Ladle Foundation, they were also very much convinced with the work. We made a WhatsApp group. Dr. Thomas was added. And, we took almost 40 facilities from these 3 states and almost 450 healthcare workers. And what Surekha was talking about, that we wanted this integration, vertical integration. So we took 4 medical colleges also on board. So wherever we were taking these facilities on board, we took medical colleges also. So Prayagraj Medical College, Ranchi Medical College, and Muzaffarpur Medical Colleges were also taken on board. And Anil, these trainings went on for 4 to 5 months, or trainings and mentoring, hands-on, holding everything. It was not a single day webinar. We used to connect one-on-one with each facility. And we made IC material, we designed the handbooks, everything was made by Safe Motherhood Committee, and we tried to reach out to each and every facility. So all the members of Safe Motherhood Committee who were in Bihar or in Jharkhand or in UP, we tried to go to the facility and train them on site. So it took almost 7 months. And after the 7 months, we did the assessment of these facilities, and the assessment was done. It was the people who were not involved in this, all the senior people. I think you also assessed one of the centers of Jeevan Dhara. And then after that, the success of Jeevan Dhara 1, UNICEF came forward and they requested us that we need training from Safe Motherhood Committee, Foxy, for 8 more public facilities in UP. So they were very distant, far away places where there is no blood facility. They are almost at the border of Nepal. And we took the challenge and we took 8 facilities on board, and we finished off those facilities. That was also government supported. And we finished off in the month of March, this March. So this was Jeevan Dhara 2. And then I was made the co-chairperson of Maternal and Perinatal Committee, SEFOG. And when I was doing one of the discussions about the PPH, I got a feedback from Nepal that they are not aware about the NASGs. So we started Jeevan Dhara 3 in Nepal. And this was again a great challenge for me, because it was putting Foxy, SEFOG, and MGH and Nepal, all 4 together to implement this Jeevan Dhara 3 in Nepal. So it was not an easy journey. But again, what Surekha was saying, that why so much of menace of PPH, because we are not actually targeting on the need. So we made the pre-training survey tools. There were 25 to 30 questions. We used to find out where the gaps are, and then we used to train those facilities. Again, alarming thing is that in our country, still active management of third stage of labor is the biggest challenge, I must tell you. That's a prevention. And still active management of third stage of many of the OBGYNs, they are not aware about the 3 steps of the active management of third stage of labor. Diagnosis, prediction, again, a lot of things are there that they are there as the challenge for PPH management. So this is what we have done so far, Jeevandhara 1 and 2 and 3. And government of Uttar Pradesh has also taken on record that we are doing such work. And probably we will have the dissemination on 28th of this month, where all the government officials, all the international organizations and Dr. Thomas Burke are joining in Lucknow on 28th of August for lessons learned, teachings for Jeevandhara 1 and 2 and 3, and also for the PPH project that was going on in 10 public facilities. So it would be on 28th of August. So a lot needs to be done still, what I feel, but things are going on. And I'm really surprised that, I never thought that I would be, heading so many of international organizations. Everybody was so cooperative. There was no MOU signed with Foxy, nothing. It was only, just looking at the work, they all came forward and they helped us and supported us. So now we are looking forward for the funds because we don't have funds. So if we have funds, probably we will do much more work in PPH management. And I still feel private sector, I think the government should also stop the distinction between the private and the public sector. They should take both the sectors, private and the public, together for the training, because a lot of the public sectors are trained by the government, the private sectors are still not trained. So government has invited me as the technical expert group for preventing maternal mortality also. But again, the question is, the documentation is a challenge again. They want the data from the private sector. They want the data of the cesarean sections from private sector. So they are expecting so many things from Foxy, because recently we had the meeting, they were asking for it. But the challenges are there, but we need to go ahead and we need to work on the ground realities and focus on those ground challenges. What are the challenges in these facilities? And then we have to work and step forward.
Definitely, we have seen not only the academic quality, your academic quality, but the leadership quality. The huge team was working under you with a single motto: prevent maternal mortality. Even I still remember I assessed one center at Jamshedpur,
Yes.
and I was just asking a question to that ANM. And I still remember that I was just had a feeling that she had been trained in such a nice way that I feel for sometimes that I am taking a YY of an undergraduate or a postgraduate student.
Yes,
She was
yes.
perfectly answering to every question, and I on that day also I appreciated not only the trainers, the way they have trained to these people, and definitely it has achieved a goal what you want.
Sanil, I still remember the message that you forwarded after that assessment, and I have saved that message. Still, I have that message with me. And really, it is not a one-day webinar. It almost takes 7-8 months. It's a vigorous hard work. You have to connect with them. You have to catch hold of them. कई बार आते नहीं हैं, लाइन पे जुड़ते नहीं हैं हेल्थ केयर वर्कर्स, फिर पकड़ो उनको कि नहीं, you have to be connected with this, and then we felicitate them, we honor them, and then this is a kind of they get the boost and then they start working for the trainings.
You crossed out our borders, not only in India, and started working in Nepal. So how did it happen, and what are the initial challenges to work there?
So actually, Anil, I just told you that I was, appointed as one of the co-chairperson of the Maternal and Perinatal Committee of CIFOG, and we were having one of the discussions on the panel. Snigdha is one of the professors in Paropkar Maternity Hospital. She said, we are not aware about the ball and binder. They call NSG as ball and binder. So I just talked to her, why you are not aware about NSG, what are the challenges? Then she, started telling me that we have a huge hospital with a delivery load of 25,000 to 30,000 deliveries in a year. but they don't have the NSGs and they are not trained for the NSGs. So that actually clicked in my mind. And then I talked to Dr. Rohana sir. Sir, why not start Jeevan Dhara 3 in Nepal? So Dr. Rohana was very much, disturbed. Should we start FIGO, this thing, and bundle approach? They may object on this, and let us talk to Dr. Thomas Berg. Then, I have to talk to Dr. Thomas, then Dr. Rohana, and then President of Nepal, and then Dr. Shanta Madam. Everybody was brought on the same platform, and then everything, went on, and we started this. When I was, when we were having a conference in Indore, that was the time when we did the hands-on training there in Nepal. So, and you will not believe the trainings that we did in the Paropkar Maternity Hospital, they gave us 5 more facilities. Now UNICEF is ready to fund that project. So that's a great thing, because UNICEF was a part of Jeevan Dhara 1 and 2 here. They supported Jeevan Dhara 1 and 2 in the form of IC material. Now they are funding Nepal for Jeevan Dhara 3. So that's a good thing. And government of Nepal has also approved the trainings of Jeevan Dhara 3. So that's a big achievement for Foxy also. And we feel proud of training our neighboring countries. And probably we will take the lead. Dr. Poonam, myself, and probably Dr. Thomas sir is also there. And again, now Pakistan is also coming forward. And they have also, they also are there in the channel, and they also organized the meeting, and I was there for the Pakistan meeting also, and probably they have prepared the concept note, and in the Silver Jubilee conference of CEFOG in Sri Lanka, they will also, come forward for training the PPH. So that's the motivation, the kind of a motivation and a drive, I must say, लहर जैसे कहते हैं ना, तो वो लहर एक PPH की जैसे चालू हुई है. Or I really enjoy, because wherever I get time, where I get opportunity, I organize workshops. So that's like a Jeevan Dhara workshops. And whenever I get the opportunity, I train the facilities. That trainings goes on for 6 or 7 months. So there are 2 kinds of trainings that we are doing. One is workshop, that is half day or full day workshop, and that is also for the doctors and the healthcare workers. And another one is when we take it's like a manyata, that we enroll the facilities, and then we collect the data, and then we take their, how many PPH they are having, how many they are managing with their response bundle, how many they are referring. So that's the thing that is going on. So it's also a new journey for me, but I'm, enjoying this. Probably I have not done much of the webinars. Safe Motherhood Committee is never seen on the webinars, but most of the time is spent on, for last maybe 2 years, I'm just working hard only for the training of the healthcare workers and the doctors. Healthcare workers know more than the Foxians. They know me more than the Foxians. So that's the thing. So I keep getting messages from healthcare workers, Madam, when is the next training? When is the next training? So that's a good thing that we have achieved.
Yes, the feedback of these paramedics is very good regarding this training. So we are very eager to know, and we will be very happy to know about the PPH EMC module which you made for training the various modules you made to train these paramedical workers.
So, Anil, it is basically a FIGO PPH bundle approach, and the entire training package has been designed by Massachusetts General Hospital under Dr. Thomas Berg. So the patent right is Dr. Thomas Berg is having. And believe me, this is very simple. People, learn very soon, because whenever you organize workshop, you talk to them, how you manage PPH. Somebody will say, I'll put Vigo. Somebody say, I'll call for help. Somebody will say, I'll put crystalloids or IV fluids. But nobody answers in a comprehensive way. So PPH bundle, whenever we teach them, it is very receptive. Healthcare workers and doctors understand very well, because recently also we did in Prayagraj conference. That was a Foxy conference, huge attendance. We wanted only 50 participants, but it happened 91 participated, and it was also endorsed by CEFOG. So it's basically Dr. Thomas Berg and FIGO, and we are just implementing it. But we have made a very simple handbook for the healthcare workers that has been designed by Safe Motherhood Committee. So we have made handbooks for the doctors also and for the healthcare workers also. Wherever we go, we try to distribute these because they are all printed by UNICEF. They supported us, and we distribute these handbooks to all the healthcare workers and doctors. So in Jeevan Dhara, we also donated NASGs, also to the PSCs and CSCs, but government is not advocating NASGs. They don't advocate NASGs, but we donated NASGs to CSCs, which are at far off places where they don't have the blood facilities and they are saving lives. So we are putting it very strongly to the UP government that NASG should be provided to each and every facility, maybe CSC or PSC.
That's so. With, you might be also studying the results of these trainings now. So it has been in the last 2 years you have started the training, and you might be also studying the how it has been helpful to the reducing the maternal mortality rate. So how far such trainings will help us in reducing maternal mortality rate, especially in an area you have worked?
So what happens is, Anil, whenever we do webinars or training, it is very difficult for us to assess how much they have learned. So what we have designed is we have designed pre-training survey tools. That means they have 25 to 30 questions. All the healthcare workers and doctors are supposed to do on-site, fill up those survey tools. They are simple MCQs. And the same questions are asked after the training. So then we compare how much is the difference between the pre-training and the post-training. Sometimes we fail at some point of time, and then we again, train on those points. And then after the training, we make a separate tool for the assessment. That's a separate tool. So one is the questionnaire, that is pre-training, post-training, that is same. And then the assessment tool is different, that is given to the assessor. And on those points, the assessor assesses it. So now we are collecting the data from all the hospitals. We have all the data from Jeevan Dhara 1 facilities, definitely Jeevan Dhara 2, since they were government hospitals, they were CSCs. We cannot collect the data, but definitely we did the pre-training and post-training survey, and it showed a marked improvement. So that is why now UP government and UNICEF are requesting us to take the other, parts like preeclampsia, anemia, GDM, and other components of antenatal care. So we are just working on that, and we are collecting data, and probably I told you that dissemination meeting is on 28th of August here in Lucknow. So everybody is coming, all WHO, UNICEF, everybody, every head of the organization is joining here. And we will be presenting the data, and the Jeevan Dhara data will also be presented. So definitely it is making a lot of change. We keep on, sharing the stories of the from the facilities, how they save the patients and all. So definitely it is helping. These trainings are helping a lot.
Okay. Does this training, Jeevan Dhara training, include the mock drills or all like that to have?
So
a
now
perfect...
now we have shifted to simulation trainings, because in bundle approach we were taught about the simulation trainings. Simulation mein ye difference hota hai, it is like a live situation. Like suppose a patient is bleeding. Now the vitals are this much. And after sometimes the performer, the ORRT has to respond to it. The obstetric rapid response team has to do the management. And then suddenly the facilitator can change the vitals. They can say now the patient, the bleeding is not controlled. The blood pressure is falling. The pulse rate is rising. Now what next? So we have to these are all simulation based training. So there's a difference between initially we used to tell them about the drills. Now we are talking about the simulation drills.
That simulation. Will be very, yeah. That will be very much effective in coming days. So, as a Foxy Safe Motherhood Committee chairperson, what are your long-term goals in curbing the MMR, to reducing the MMR?
So what I have found, because Anil, I have a personal experience of working with all organizations like WHO I worked with, UNICEF, JPIGO, Pathfinder, every organization, I have a good experience of working with them. But what I find is that suppose USAID is working in particular state, the JPIGO would be working in some other state. So I just want that all the organizations should, interconverge. They should join hands together and start working on those areas where the maternal mortality is high, like Assam, like Bihar, like UP. So I want, because UP will be funded only by Bill Gates. USAID will not interfere in this. It will be only funded by Bill Gates. So that is the basically, because I'm going to take up this question on 28th of August. Why not all they are funding for the proper cause, proper this thing. So definitely I need funds for the training, and I got a call from few of the organizations. Definitely I'll have to talk to Dr. Shantakumari ma'am and probably Dr. Pai. and they will have the MOU with Foxy, because definitely funds would be involved. JSI has approached us, that is a USAID supported agency, and we want to go ahead with PPH trainings in Uttarakhand and MP. So these are the two states where I've selected that I will be working in Uttarakhand and MP. So that will be again a new challenge for me. Still, we have to take the facilities on board. It will not be a webinar, but definitely a long, process of collecting data and then look at the facilities, how much they have improved. And the next thing is, and the last what Surekha was telling is, we have made a WhatsApp group, and I'll request everyone to do that if it is not done. I have made a WhatsApp group from KGMC, that's a tertiary hospital, and I have connected this to Jeevandhara facilities, the facilities which I have taken. So it's a WhatsApp group where they put the case that I'm referring so-and-so patient to KGMU. This is the patient, she had the PPH, I put the balloon. So KGMU people are ready with the everything for managing that patient. So it's not a phone call, it's just a WhatsApp group. And I'm also trying to add Manyata facilities also in that. So we have almost 25-30 facilities of Manyata in Lucknow. So I'm connecting these Manyata facilities and Jeevandhara facilities to KGMU, that is vertical integration. Similarly, I'm doing at every place, like Allahabad, I'm doing it. In Ranchi, I'm doing it. Muzaffarpur, I'm doing it. So I'm making it a WhatsApp group where they can normally put any patient where, not only PPH, maybe eclampsia or whichever patient they are referring to, that is put in the WhatsApp group, and immediately the person from the KGMU will respond to it. And this WhatsApp group is also there for the government facilities. So all the CSCs and district hospitals, 5 facilities are linked with KGMU. So we keep on seeing those messages, and it's really great because we are saving a lot of lives. And if they are not managing properly, we also tell them that you should, do it. Just one example, because we are just coming to the end. One of the patient of PPH, that patient was a case of placenta accreta. The patient was operated at CSC, and then the patient started bleeding. That CSC was enrolled for this PPH project. They knew how to put the PPH, the catheter, ESM-UBT. So the doctor, she applied the ESM-UBT, and after that, the bleeding did not stop. So what she did is, she put the B-Lynch on that same catheter. So, and then she referred that patient to KGMU. So this was a blunder that she did, that putting a catheter and then putting a B-Lynch is not possible. And what happened is that the B-Lynch, suture came in the catheter, and then it was again a problem. So this kind of cross communications, when they are referring, and then the tertiary center, they tell them that this is not done. Whenever you are doing a surgical intervention, you just remove that catheter. Because B-Lynch, if you are doing, you cannot do the B-Lynch with catheter on. So this kind of, these are small things. Like recently, just 2 days back, district hospital, they referred the patient to KGMU. The patient was in shock, but the NSG was not applied. Though it is a part of training, but NSG was not applied. And the patient came in a collapsed state at KGMC. So this, we responded back to district hospital, please do tie the NSG, apply the NSG when you are referring a patient of shock. Even if you are not having the blood, at least you can save the life of a mother, even if you apply NSG. So these are small things that we can do at our own level. And I think everyone has a responsibility. Even if you want to train your own healthcare workers, just frame some questions and ask them to do this. And then you can just find out the gaps and then do it. So Dr. Sheila Mane said it's a sandwich. I know that's a sandwich, but for the facilities like CSCs, where they are not aware about the application of any this catheter, because in the training also, we are telling all the CSCs and district hospitals that you just put the catheter and send the patient to the tertiary center. Do not remove the catheter, do not remove the NSGs. So we are just telling them how to apply NSG and how to put the ESM-UBT. We are not telling them how to remove NSG and how to remove the catheter. So at the periphery, you have to, just tell the healthcare workers that they should apply NSG, they should apply ESM-UBT and refer this patient to higher facility, because they are not well trained on those things. So gradually when you go, then you learn so many things, because a learning step for me also. In Varanasi, one of the district hospital, they said we are not able to put the ESMUBT. Then we inquired why you are not able to put it. You know how to put it. Why you are not able to put it? Then she said, you know what we found is they are not removing the clots when the patient is having PPH. So the patient is pouring the clots in the uterus and they are putting the catheter. Catheter is not going inside. So you have to evacuate the uterus first and then you put the catheter inside. So these are small things when you go to the facility and then you learn so many things. So my journey had been very wonderful, and I really feel privileged and honored to be part of this forum. Dr. Thomas and Dr. Sheila Mane both are my teachers, and they are inspiration for me. And I must say that Dr. Thomas he's a wonderful person, and I know him for last 2 years since I'm attached to this project. Very supportive and very helpful and very encouraging. And he also stepped forward for supporting Nepal, and he donated 100 ESMUBT to Nepal also. So 200 he donated to India, and every facility of Jeevandhara, they were given ESMUBT free of cost. So this kind of work we are doing. Probably some changes will happen, I'm sure about it, and we will take this ahead. And probably in days to come, a lot will be done for the private sector, I must say.
So this will be the last question before we conclude this beautiful interview. The first part of this question is, do you have any initial figures that says that the Jeevandhara project is, because 2 years is not a very big time to say that we have reduced a substantial percentage of maternal mortality. But what does initial figures say?
See, the data that we are collecting is, there are 2-3 things that we find are useful. Number one is the documentation has increased. So initially the prevalence was 5 to 6%, incidence was 5 to 6%. Now, since they are documenting even in a small trickle of PPH, it has increased to 8 to 9%. This we are finding in every facility, the private and the public facility. So the PPH incidence has risen, maybe because initially they were not documenting. The referral has become strong. Early identification in these facilities have definitely improved. The identification of PPH again is improved, because now what Dr. Thomas was saying is that the bleeding, any amount of bleeding that has the potential to deteriorate the condition of the mother is called PPH. So if you see the facilities, most of the, when I went to Sirsia CHC, 100% of the antenatal patients were anemic. They were having an hemoglobin less than 10. I think tranexamic acid is a wonder molecule for them, what Jaya was mentioning. So it's a wonder molecule. And Women 2 trial, we are waiting for anemia and tranexamic acid. They only depend on iron sucrose. They don't have, there is a stretch of 20 kilometers of jungle before they reach to the district hospital. So India, a lot of things need to be done, even for the public sector and also for the private sector, because the private facilities are also there when we go there, and it is very difficult for them to convince that you get enrolled for this. Bahraich, I enrolled 4 facilities for Jeevandhara. It was difficult for me because they have a huge load of patients. Very difficult to spare time for the healthcare workers to connect to online. So, but definitely you have to be after them, that you have to do it. You have to do it. You will get the certificate. So we, fascinate so much, a lot of efforts are needed. You talk to them, convince them, they drop out, again you connect to them. So it's a lot of hard work, but definitely learning steps. We are also learning, and probably Uttarakhand and MP would be our next target, and we will go ahead with this USAID supported project, and probably GSI will do it, and we will soon start that in Uttarakhand and MP. Maharashtra, we were supposed to do it because Dr. Niranjan sir several times said you start Jeevandhara in. I wanted funds for that. I requested WHO to support Maharashtra, and WHO is also ready because they want to include labor care guide for implementation. So probably the next step would be I'll request WHO, because if it gets endorsed by WHO, so WHO and Foxy together doing in Maharashtra, that would be good. And the healthcare workers getting some kind of training and certificates, that would be good. So I'm clubbing probably Jeevandhara with labor care guide for Maharashtra. So Dr. Niranjan had been kind enough, and he had been requesting me to start in Maharashtra. But soon I will definitely try to work out with WHO, and probably in Dr. Pai's time we can start this very important, because labor care guide is again a new concept, and we need to teach every healthcare worker and doctor about the labor care guide, because the definitions are changing. So we have to adopt this labor care guide. So probably in days to come, we will definitely start. We are going to start soon. Kasoga is pending. Kasoga Jeevandhara. Dr. Hema and Dr. Vidya are also working on it. And Maharashtra will soon start. And anybody can take it forward. We can just do it and anybody can take it forward. Anybody, even Jaya can take it forward. You can take it forward. Anybody can take it forward. They're simple modules. You have to just have it in a local, because in Trichy, we did it in local language. So it does make a lot of difference.
Yes, it's a very, very huge mammoth work. You are working for the well-being of women in the to reduce the maternal mortality, and your
Anil,
work
वही है
will
ना,
be a big.
हम लोग भागते हैं ना कि बिलिंज कर पाएंगे कि आइलिक लाइगेशन कर पाएंगे कि नहीं कर पाएंगे. उन फैसिलिटीज का देखो, CHC में जहां दे आर डिलीवरिंग 300 डिलीवरीज इन अ मंथ, नो सर्जन देयर, 300 deliveries in a month, they will not be able to do village also. ना ही आइलिक लाइगेशन करेंगे, but 70% would be definitely what Dr. Sheila Mane said, 70 to 80% would be managed by your proper medical management. So that we need to, embark upon.
Yeah. A few years back, Dr. Shirish Patrodhan said, asked me to make a modular first aid in obstetrics, and it was unfortunately we could not popularize it because of some, but we had made such a very good module on first aid in obstetrics. It was a very novel idea by Dr. Shirish Patrodhan, and she made me in charge to make it. But unfortunately, it was not that much popularized on the platform AMOX, but still we hope that it.
But we need Anil, we need good team, and I must thank all my members of Safe Motherhood Committee. They are really working very hard, and they are very committed. That is why we are going ahead with such kind of work in the. And now every organization they want Safe Motherhood Committee to work with them and implement those. So IP Global, every organization. So we have good experience with them. And definitely Foxy is a big organization, a big platform, and lot can be done. Lot can be done for the women's health.
Okay, yes, definitely your work will be a very big milestone for the youngsters who are watching this, and even it will be remembered for years. I really congratulate you for your such work. Once again, on behalf of AMOX, I thank you to be with us today and sharing your views, ideas, your work and concepts for the work of reducing the maternal mortality. I once again thank you, Dr. Rashmi ma'am, Dr. Rajendra Singh Pardeshi madam, Dalvi ma'am, Kiran, Jaya, for giving me this opportunity to interview such a wonderful lady. Thank you very much.
Thank you, Anil. Thank you so much.
Thank you so much, Dr. Preeti Kumar madam and Dr. Anil Sakre sir, for such a great interaction. Training of paramedics and vertical integration is so much important. We are just mesmerized to see your working zones, broad zones, ma'am.
Yeah, I just want to tell you that, Safe Motherhood, the work speaks aloud. So yes. We got appreciation from USAID. Sangeeta Patel gave me the letter of appreciation. Dr. Thomas Burke sent me the appreciation letter. Jean Connery, FIGO president, gave me appreciation letter. So many, UNICEF head office gave me appreciation letter. Japaigo, they appreciated the work of Safe Motherhood Committee. So you also feel good that whatever you are doing for the community and society, that is worth it.
Really, I must congratulate you for this so much work for prevention of PPH, and I will be happy if in future I could join you somewhere. If I get a chance.
करना पड़ेगा. ये भी हम लेबर केयर गाइड का और PPH का जब महाराष्ट्र में करेंगे, निरंजन सर ने कहा है, निरंजन कोल्हापुर वाले जो है निरंजन शाह.
चौहान सर.
तो नहीं नॉट चौहान. दूसरे डॉक्टर निरंजन शाह. तो वो उसमें फिर सबका करना ही पड़ेगा. You'll have to take it ahead because थोड़ा सा कर देंगे आगे तो तुम्ही लोग को ले जाना होगा.
Yes. Thank you so much, ma'am. We are honored to have you here, and thank you so much for sparing time for us.
Thank you.
Thank you, Jaya.
Yes, ma'am. As we are concluding this webinar, would like to propose vote of thanks on behalf of our AMOX committees, High Risk Pregnancy Committee, Emergency Obstetric Committee, Website Committee, and Amravati OBGYN Society to the esteemed guest, respected Dr. Rajendra Singh Pardesi sir, respected Dr. Sujata Darvi madam, for showering their blessings for the webinar. I would like to thank our eminent respected speaker, Dr. Thomas Berg sir, Dr. Sheila Mane madam, and respected Dr. Preeti Kumar madam, our respected interviewer, Dr. Kiran Kurkoti sir, Dr. Surekha Tade madam, Dr. Anil Sakre sir, for their wonderful presentation and sparing time from their busy schedules. I would also like to thank our conveners and chairpersons, respected and beloved charismatic personality, Dr. Rashmi Khar madam, for giving me this opportunity to conduct this webinar, Dr. Chaitanya Shembekar sir, Dr. Pranjal Sharma madam, Dr. Suyoga Panath madam, and Dr. Anita Bobde madam, and organizing team for this webinar. Thanks to Corona Remedies and Core Connect, and special thanks to Abhishek Shah, without whom smooth conduction and telecasting of this webinar could not have been possible. Thank you all of you for being here. Thank you guys.
Thank you, Jaya.
Thank you, ma'am.